Hi, this is Dr. Yasin. Today I am going to present a case of tibia non-union. In case scenario, a 5-year-old girl which is otherwise healthy with normal birth and developmental history and up-to-date immunization presented with long-standing history of pain in the right leg upon weight bearing associated with deformity. Her previous medical record and past history shows gradual onset of swelling in the right leg followed by purulent discharge. For this, 5 sessions of debridement were done in the span of last 8 months. On presentation, she was a well-looking child, very cooperative, sitting comfortably in the couch with unremarkable general physical examination, and systemic examination was perfectly normal. Her vitals were in complete normal range. Upon local examination of the right leg, there were mild swelling with a varus deformity. There was no shortening but multiple incision scar marks that were corresponding to previous surgery. There was no active discharging wound. We could appreciate abnormal movements at the mid tibia on the right side that were movable in 2 perpendicular planes. The distal neurovascular status was intact. The power in that limb was 5 by 5 and the range of motion in joint above and below were normal. We performed lab investigations to rule out any active infection. The ESR, CRP and white cell count, all these 3 inflammatory markers were in perfect normal range, while the hemoglobin was 11 gram per deciliter. These are the planned radiographs taken on the presentation of the patient. In these, we can see the AP and lateral projection of right tibia and fibula with knee and ankle joint exposed. There is the epiphyses that can be seen. These are not closed. The fibula seems to be perfectly normal. The tibia, we can see a gap of about 7 to 8 centimeter at the diaphysis, while there is also a hypodense regions within the tibia, corresponding either due to osteopenia due to infective process or due to disuse atrophy. So the diagnosis is clear. This is a gap non-union, and from our history that I have told in the earlier slides, it was initially an infective process. So this was basically chronic osteomyelitis of the tibia, right? And from this chronic osteomyelitis, there occurred pathological fracture, and now it is a gap non-union of the tibia. So there are different treatment options, including Ilizarov or any other external fixators and internal fixators, and different types of bone grafts: cancellous bone graft, fibular strut graft, vascularized fibular graft, and even we can do the tibiofibular synostosis. So this is what we performed. We trimmed the tibia metaphysis edges for refreshing them, and we took ipsilateral fibular strut graft subperiosteally. Okay, the sleeve of the fibula that was left intact, we sewed them back, and after 1 month follow-up, you can see in the X-ray from the leftward sleeve of the tibia, right? If you see here in the previous slide, we have removed the diaphysis of the fibula, but on follow-up after 1 month, we can see the fibula has been completely regenerated from the sleeve of the periosteum. But unfortunately, this was the condition of the wound. This was basically because of the poor post-operative wound care, as the patient belonged to a very poor socioeconomic status and from a far-flung area. We can see there is a dehisced wound with profound discharge, deformity, and the part of the graft that is visible in the dehisced wound. So we decided to do debridement. We washed the wound with plenty of saline and we took deep cultures. Aseptic dressing was applied and backslab was given for support. The culture report showed growth of Enterobacter species that were sensitive to cephalosporin sulbactam combination. At this stage, it was decided not to remove the sequestrated tibia. Upon second follow-up after another 1 month, the patient again presented with a dehisced wound with exposed fibular graft. Here you can see the regenerated fibula that is normally growing and is more stronger as compared to the previous slide. It is little bit hypertrophied, but the grafted fibula in place of the tibia, it is now sequestrated. So we performed sequestrectomy, we washed with plenty of saline and did debridement. Deep culture was also taken at this time, but they turned out to be negative. We just approximated the wound and backslab was applied. Upon her third follow-up, this is the condition of the wound. As you can see, there is optimal coverage of the underlying bone. There is no active sinus or open wound. And this is the X-ray. We can see the regenerated fibula is perfectly normal with just a mild deformity, while the sequestrum from the tibia metaphysis that has been the tibia diaphysis that has been removed by now, but we can see from the underlying membrane and from the edges of the metaphysis of the tibia, especially from the distal metaphysis of the tibia, new bone is regenerating slowly and gradually. This patient is in our complete follow-up, and the last visit of the patient was done on March 5th, 2022, and inshallah the progress of the patient will be shared with you. Thank you very much.